I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
So welcome, everyone. Thank you for joining our living room. We are so happy to be here in Nashville, bringing you this special edition meeting from our Center of Excellence Summit. We are thrilled to be back live and in person with all of you in the room, and of course, all of you who are watching live from wherever you are watching from around the world. So welcome, welcome. Tonight's discussion, we're going to be talking about facing off financial toxicity in lung cancer. We have Alan Balch, who I think most of you probably know, PhD, Chief Executive Officer at the Patient Advocate Foundation, as well as the National Patient Advocate Foundation, and April Brake, who is a Patient Access Manager from Tennessee Oncology right here in Nashville. So welcome to both of you. We are thrilled to have you here today. We had a lovely conversation a couple of weeks ago talking about what we were going to be talking about during this meeting. And I think one of the things, Alan, that you brought up was using the terminology financial toxicity. Can you tell me a little bit about why you'd rather call it something else?
It's not so much what I'd rather call it. We are learning from patients that it's probably not the best term amongst other terms we use. I use a lot. It's a good reference point. We finally got a term that kind of got the health system thinking about not just the clinical dimensions of care, but really accepting the fact that there's other parts of patients' lives that are separate and apart from their clinical care usually, but have a tremendous bearing on their outcomes and their ability to access those outcomes and achieve those outcomes equitably and effectively. So it's really important that we bring these things into the health system in terms of the conversation and we think about the care of patient. But I don't want to say it's a bad term, but it also kind of over clinicalizes and over traumatizes the experience for patients that are already scared enough about having a cancer diagnosis and everything that comes with this. And now we're introducing another scary term, financial toxicity. And we'll unpack it a little bit more, but I also think, it also tends to kind of put this in the context of something we're going to think about and manage after you've been diagnosed and after you have a treatment plan and once you've started your treatment journey and you start to see side effects. But what we've also come to learn about the journey of financial toxicity is it's a progression just like cancer. And if you wait to start seeing sort of signs of financial toxicity, like splitting pills, not showing up in the chemo chair, et cetera, you're pretty far advanced in your progression. And there's a lot less you can do. And what you have to do is far more invasive. So we have to start thinking about how do we, and I know get into this, how do we normalize these issues around social risk and financial need early and often into the treatment and care conversation so that patients know that these are important aspects of their care. We don't have the terminology yet, but I think the real essence of it is that this is part of whole person care. And these are the ways we're going to care about you as a patient. And they include your lived experience, your life experience, and your personal needs and your social needs that are relevant to, but different than your clinical needs. And I think that's financial toxicity kind of flips it into that clinical bucket. We're going to manage it just like nausea or neutropenia or whatever. Nothing wrong with that. That will have to happen. But let's sort of think about this as another way, as whole person care and really caring about you as an individual and a human being.
Yeah, thanks. And April, when we're talking about this financial toxicity or financial distress, what are some of the most common things I think that you see that people who are diagnosed are challenged by?
Yeah, I think when you think about the financial risk, I mean, we probably think about the out-of-pocket costs. So the direct impact, but there's also the indirect impact that goes along with that. So not only do you have the out-of-pocket costs, but there's also during the journey, whether it's transportation or loss of wages, or even of your family members that are assisting with you to get you to treatment, there's a loss there. There may not be barriers up front, but talking about those prior to treatment and letting patients know, of course, as we're going to talk about, how they will be impacted during their journey. So those are the things that we're talking about with our patients up front. They may not have those distress now, but they may later on, and just educating prior to experiencing the distress.
Yeah, I remember when the three of us were having this conversation a while back, food insecurities kept coming up like throughout the entire part of this. And I know we're going to jump into how to and when best to do this type of assessment. But Alan, do you have anything to add before we?
No, I mean, we hear the same things. And I think when patients are seeking help after these things have presented themselves, and I think that's a key thing to remember, when you're waiting for patients to ask, there's a lot of problem. And I'm not saying we need to be asking them all the time, but if the system is set up to sort of wait for them to ask or wait for them to ask for help or try to find help, A, they're in pretty dire straits, and B, there's a power dynamic in who's even confident enough to ask for help, and the stigma and shame that comes. I mean, I know the stigma and shame that comes with lung cancer. Now you add on top of that the stigma and shame and saying, I can't afford food, I can't afford housing, I can't afford transportation. So there's things that we can do to try to take the stigma away, and we'll talk a little bit about that.
Mhm.
But it does manifest itself, in the clinical journey in really acute, specific things. It's not financial per se. It's transportation. It's time off work. It's utility shut off. They're really specific instances of a particular struggle that a patient is having. And I don't know if you're sports fans, but sort of a football analogy is, you're not going to win the game by addressing these things. But if you don't address them, you're not going to get another set of downs. So a lot of this is just getting a fresh set of downs for the patient. They get to a point where it's fourth and inches, and just keeping their utilities on is going to be the difference between them falling off treatment or staying on treatment, for example.
Is there a way to normalize this conversation, and when are patients ready to have this conversation? When should they be having it, but when are they ready, April?
I don't know that they're ready, but having them up front, talking about those cost coping skills the patients are going to go through, whether they even foresee it happening or not. So whether talking about, not paying your utility bill so you can pay your prescription or your medical bill, because you don't want to go to the office back to treatment because you haven't paid. So you'll let this go. Or maybe it's lack of food. And that's, a big focus for Tennessee Oncology right now. We always knew transportation was a big need, and we've did a lot of focus there. But over the last year, we've really seen that food and nutrition was really big. Sorry, going around your question there, but up front. So prior, and then actively monitoring throughout the treatment. So not just, when they bring it up, not just at the beginning, the entire time.
And is more than one person on the healthcare team monitoring, or is it up to one person?
I think it's really important that you build those relationships with your physicians, with your front office, with your lab, with your MAs, your counselors, your navigators, everyone who's involved with that patient's care at some point, that everybody knows what's available for that patient and that the support that's there, and that if it's not there, that you build it for that patient. Because we all talk about what impact financial distress or financial toxicity has on your overall care, but what are you doing about it? What support are you providing to the patient? So making sure everybody is aware of the support your practice or your community has for that patient, and then looking for those flags. I always tell our nurses, like, if a patient's in the treatment room and they're at the snack bar and they're putting extra cookies in their purse, let us know right away. Or just in conversation with patients, and I haven't ate all day, or I don't know how I'm going to get here next week. And most patients have a support group, but not everybody does. So it's really hard when you're the only person that patient's speaking with, and they don't take that home, or there's no one home to take it home to. So I think building your community within your practice is really important for your patient's overall success.
As I shared with you guys, and I think some of you may or may not know, at GoTo we have a helpline, and we field a lot of calls very similar to this on the helpline, and Maureen's sitting out there and Michelle's over there. And I think one of the challenges is, even if you have identified, or if somebody is actually reaching out for help, then sort of what, right? And that was exactly where I wasn't going to go a second ago when I said I wasn't going to talk about challenges yet, but it just keeps kind of creeping up in my mind. Like, it's a bigger problem, right? And I commend you guys for having this program put in place and workflows behind it where you are actually paying attention, because I think it's one of those things, particularly with patients when they're in seeing their healthcare providers, there's not a ton of time, right? So they're in and they're out. And so you have to have sort of this keen eye, is what I'm sort of hearing. But it's not just one person on the team. It's multiple people. Alan, do you have anything to add?
Yeah, I mean, I guess starting from another insight we learned from patients, and again, these are low-income patients who have a significant life-threatening and debilitating disease like lung cancer or other cancers, rare disease. And when we ask them, like, what's important to you, not just from an abstract, open-ended, but giving them a list of typical things that you would see, like, EQ5D kind of questions or efficacy and safety questions. So we give them a long list and they sort of rank order, prioritize those. And actually, for our patients, the most important thing for them as a goal of care is avoiding extreme financial ruin. More important than short and long-term clinical side effects, and more important than even dying. They're more afraid of that. And again, this is a low-income patient population. I don't want to suggest this is a problem only in that population, but if your income is $25,000 a year and your out-of-pocket cost for a cancer treatment is $10,000, $12,000, that's half of your income. And meanwhile, you're losing your income because you're spending more time in treatment, and your caregivers are probably helping you take you to and from treatment, involved in your treatment. So they're losing income too. So at the same time, your out-of-pocket expenses are going up, your money coming into your pocket is going down. So that's kind of this downward spiral that patients are on. And obviously, where you start from in that financial journey is going to have a whole lot to do with how difficult it actually is. But anybody, even people with six-figure salaries, can get caught up in that maelstrom of financial devastation. So I say that just to say this is not a nicety. It's actually a necessity, and why we have to really integrate it. And I love that April's here because, and we do a lot of practical work too, but I'll probably stay more in this stage, more on the normative side, like how can we do better and what should the system look like? It's great. And we're part of that reactive system, but we have to do better than just react to these problems. We have to actually set up a system by which we start to think about these issues as part of care selection, as part of care planning, and then part of patient management. So we'll talk about that here in a second. Sure.
Yeah, I mean, we can start talking about it now. Because you're basically talking about standardizing this, right?
Yeah.
So tell me what good looks like there.
Illness is very personal, obviously, and these are very personal dimensions of illness beyond just the biological, right, and the genetic characteristics of the disease. These things are extremely personal, and so we have to talk about them, and we can't wait to start talking about them when they present themselves, which is how we set it up now. So I think early, and you even heard some of it, patients are, I'm not a candidate for surgery because I can't afford the transportation. So these are not factors that we use to determine whether a treatment may work. I mean, you actually may have a treatment that differentiates based on how much transportation or how much time off work, great. But normally it's the standard of care is X. We want to make sure you get the standard of care. We want to make sure you're successful in your ability to have a shot of completing that standard of care. So we're not just going to talk about the clinical aspects of your journey. We're going to start talking about the other things that we know you're going to need. And these are not conversations necessarily for the doctor or even for the clinician, right? So a lot of this can be done. You're like, where do we get the time for this? This is where technology can actually be a real tool, decision support tools, other ways of gathering information from patients, because they also tell us they're very happy sharing this information online, right? It's almost for some patients a little awkward to have these conversations in person. So this is information that can be gathered from the patient at different points without an actual conversation. And then the real meat of the information can be distilled, just like you're reading a patient's chart before you go in to see them. You may see some other information about them that we need to talk about these other issues. Like, how are we going to plan? So we're not worried that you're not going to be a candidate for surgery because you can't manage the transportation. We're going to help you figure that out, right? So care selection, care planning. And now we know what are some of the things that are trigger points and pressure points for you. We can start to measure and manage those things more effectively as you go through your treatment progression.
Actually implementing it, I think, is different, right? Because not everybody has financial navigators or social workers on their teams. Like, I don't know how many of you, like a raise of hands, how many of you have social workers and financial navigators on your healthcare teams?
Yay.
So that's a decent amount. That's actually more than I thought there was going to be, which is fantastic. So now we can get into the implementation part, right? Because it's saying it and implementing it are two different things. So April, when you guys made this sort of commitment that this was going to be something you guys were going to buy into holistically, not even just from a care standpoint, but from a team standpoint, and we're going to make this happen. Where do you start with something like that?
When you ask who has social workers, who has navigators, we really found that you really have to separate the different roles with that, because that's, your social worker can't do everything. There's the other aspects that they're looking at versus the financial piece of it. And those conversations are handled differently as well. But when we implemented, we started off with patient advocates, probably about, 10, 15 years ago, maybe, but it all started with helping that patient reduce that out of pocket. And then it just expanded from there. And that even generated from a patient. A patient had enrolled themselves in the foundation and gave us that information, and we saw what impact it had. It changed their complete journey and their outcome, and just their vision on if they were going to survive. Because like we talk about, how are we going to pay for that? When a patient gets diagnosed, there's those two questions: am I going to live, and how am I going to pay for it? And when we get to come in and take away that second question, how am I going to pay for it, it changes their outlook. They have a more, positive view on their treatment. And we all know that what stress does, what the worry or delaying, or like I talked about, cost coping, those are big things. So when we made that decision to implement our team, there were dedicated patient advocates, but we really weren't having those upfront conversations in the beginning. We were just enrolling them in out-of-pocket assistance with foundations and copay cards. And then it just continued to grow from there. And we were helping patients get ramps built because it was hard for them to get out of the house. We were finding local community resources, making connections with the Nikki Mitchell Foundation, which is local here as well for pancreatic patients. So we continue to find ways to help relieve that distress with patients, not only with the out-of-pocket costs for treatment, but other aspects of their life and quality of life, like I was talking about. That's important. It impacts the care. And so as we did the patient advocates, in 2009 is actually when we evolved it a little bit further, and we had dedicated financial counselors. So financial counselors came into play, and they were having those upfront discussions prior to treatment, prior to cycle 1, date 1, prior to everything. Once they had their diagnosis, they knew what treatment plan they were going to get, then they got to meet our financial counselors, and they were in person at the clinic, not over the phone, in a private setting that was intimate, where a patient felt comfortable to share information. And we did a lot of training with our financial counselors prior to starting the project, because, certain words are trigger words for patients. And when a patient's been diagnosed, right in the beginning, there's a lot of emotions that are going on, up and downs. And so we did a lot of training to make sure our patient advocates, our financial counselors, were equipped with those tools to have those successful conversations. And then from there, we just continue to expand as well. And now we're into our food and nutrition focus. And we are in the middle of a project that we implemented a month and a half ago. And I had shared this story as well, but we knew that food and nutrition was a big distress for our patients, but we didn't realize how big it was. You have the distress screening where you're doing your practical problems section, talk about those things. We have our upfront conversations with our financial counselors. We're letting them know upfront about resources that are available. But when we implemented this new project where we were having our MAs during their rooming note talk about, we just gave the patient a little survey where they could just circle, have they had any, distress with food or in the last 30 days, or getting food or lack of food, or whatever, however the verbiage you want it to word. But we saw a big impact, and we made sure that we had all the resources available before the project started. But we had a really, aha moment that when we had a patient that we thought that was just, with a physician had shared that he thought the patient was just losing weight from treatment, but they were actually they were malnourished because they didn't have any access to food. And that's when we realized how important figuring out how to communicate with our patients in different ways. We had talked about how we engineer new ways to make that connection with patients, because you had mentioned too, humanity, like they just don't want to say, they don't want to admit to that, because whatever reason that may be. But finding ways to communicate with patients on what they need is what we continue to try to improve on. So we were really happy with our success of our project. And we continue to brainstorm on what's another way we can try to figure out and to communicate, to get the patient open up and let us know prior to, like we talked about, prior to having that distress.
It's definitely not a one size fits all, right?
No.
Depending, so you really have to kind of know your audience, if you will,
Right.
and who you're talking
It's
to.
the ultimate personalized medicine.
Yes.
Right. So I'm just thinking, like, when I think about this, and again, I think it's wonderful. And although I understand sort of the motions that you go through with each person that, you're sitting across from or whatever, how do we scale that? Because, and Alan, you said, there's like, even with PAF, and I know we call up, we see what's going on and we refer patients over there. And you said maybe 1,000 lung cancer patients a year.
Yeah.
That's not even scratching the bottom of the bucket,
We're just
right?
we're one part
No,
of it.
but what I'm saying is, like, how do we together work to scale something like this and find the support that these folks
Yes,
need?
this is coming. So it's here already, but it's just going to get bigger. And here's why. Every health plan that I've talked to, every drug retail store, every hospital, every clinic is going to start implementing social needs risk assessments into their environment. And we have Z codes. Who knows about Z codes, right? Raise your hand if you know what a Z code is. So there's a diagnostic set, right?
Can you just explain Z codes
It's
to
just
patients?
to
The
patients.
that are
So
that are
just like
watching.
their diagnostic codes for your disease and stages of disease, there's a set of diagnostic codes for psychosocial needs, if you will. So everything from behavioral health to emotional risk to housing, food, etc. There's a set of diagnosis codes. So there's actually, there's proposals to get them down to like the tenths and the hundredths level. So you could have a very specific, like utility shutoff notice would be, 35.12, right? So this is a way to code a diagnosis of a problem. And just like your cancer is treated, you get a diagnosis because of some sort of screening. You have a screening tool, and based on that screening, you will have a diagnosis of a psychosocial financial issue. And what do we know when you start screening and diagnosing? You have an obligation to treat. And so I'm not saying we know exactly how to do it, but the minute we open the floodgates up about assessing people for social risk and financial need, which we need to do, we're going to have to very quickly figure out how to scale this. Now, the good news is there's a lot that we know already about what's actionable and what actually is somewhat determinative of how well patients can succeed. What are the real barriers to care for most patients? And it's a pretty short list. We already kind of ran through them: food, housing, transportation, time off work, caregiver burden, right? And if you're not employed, time off work is probably not an issue, right? I mean, but maybe you're a caregiver, right? Is a father, son, daughter, et cetera, that is taking time off work to be part of your care. So it's not just, so you need to think about who's in their caregiver circle. But so we sort of have an actionable list that we know these are things that are relevant, that need to be titrated against. So that's a good thing. And we know that we can scale finance. We do that too. We divide our workforce into different sort of problem sets. So we have those that help with do the financial navigation. We have those that do sort of the enrollment work. And then we have those that help with the clinical side of things. So you're dealing with insurance companies and dealing with appeals and denials and access to clinical trials, that type of thing. So there is some ways to scale the work and differentiate it. But more importantly, a lot of this work can be scaled through like call center environments, right? It's great to have the people in your system because it helps to have that one-on-one connection. But a lot of this stuff can be done offsite through a call center. There are some things you can't scale. And the one thing you can't scale is how to build that trust in the community and build those relationships in the community. So what we need as much as patient navigators or financial navigators is actually community liaisons, people who are not out in the work, like trying to find resources and navigate for patients and doing the financial counseling, people that help understand what resources are, like what you've learned, what resources are available in the community, who are the trusted community-based organizations, and who can help you build trust with the community so that they know you're really there to help them once you leave the clinic. And you know how to connect them to the people and places where they work, live, and pray, where they can get help so that it's not all falling on the clinic. And that's the thing here. Most of the solutions here are not in the clinic. You may diagnose and screen for them in the clinic and make sure your patients know you care about them in these dimensions. But most of the solutions are going to be outside the four walls.
Let's assume, when you said it's coming, it's happening really soon, right? Which is, it's great. Soon,
Yeah.
soon is right, relative. Let's assume all of those things are put into place and now all of these people are getting these risk assessments. And I mean, there's not enough resources out there, right? There's not enough resources out there today for the people who actually find their way to the resources, right? So who's paying for it? We work with plenty of good or great organizations out there who do provide some of these services and funding, but especially in lung, quite often the fund opens and by the end of the day, it's closed. I mean, that's it. Right. So now what?
I would argue we're paying for it now. It's just a hidden cost, right? So a lot of the disparities in care that we see and the reason why you see differential outcomes in patients of low income or racial and ethnic diversities is because these things surface and present themselves and go unaddressed and they end up in poor outcomes for patients. And so we pay for that, right? If you give a patient an $80,000, $150,000 therapy and the therapy fails them because they can't navigate the transportation, the food, the housing associated with it. That's a lot of money that was spent by the system when if you would have just a little bit more help and a little bit more time and effort, you could have gotten a better value out of that money spent. I don't want to reduce this to that kind of value equation, but we're paying for this now. It's just sort of a hidden cost in the system. So figuring out how to pay for it is a way of you can recoup some of the money by keeping patients on therapy, making sure that employers get, if you're going to invest in the benefit design of a patient and you're going to pay for their care, it's actually not that expensive in a lot of cases. And some of the help that's available, getting patient to SSI, SSDI, Medicaid, a patient, if a grant is open with the charitable copay foundations, some of those are pretty sizable awards and they're good for a year, $5,000, $10,000, $12,000. So it's not all just nickel and dime. Some of it is, but for some patients, there's some pretty significant, and again, that's how you scale it, right? There are some triggers, if you can flip them for a patient, it actually leads to pretty substantial benefit for that patient financially and practically and otherwise. Not every patient qualifies for those patients, but there's a lot of low-hanging fruit out there in terms of, disability, long and short term, getting paid. Here's another good example. A lot of patients have multiple choices when they're enrolling in their insurance plan. We find for a lot of patients, if we just do a benefit analysis, they're better off now that they've got a cancer diagnosis and changing the plan that they have to a different plan that is designed for patients that are utilizing the system more. So just that flip, getting them into a different benefit design within their insurance options can actually be a better financial choice for that patient.
Yeah. So insurance optimization.
Yes, thank you.
Going back to where this whole conversation started, what are some real world examples of the people in and around your center that they're challenged by? And are you able to help all of them with all of their needs?
We have resources that we already knew about, but we didn't know about them before in the years past. And I think it's called Wings of Angels or Angel Wings, but it's a flight or Wings of Flight or something. But they'll fly a patient out to wherever they need to be, and having established relationships with your community, like we have the Hope Watch. We have, relationships with other hotels and discounted rates or free lodging for patients, the hospitality house within Nashville. So we continue to build these relationships with our community, just with the community, not just your community partners and physicians, but and asking them to also advocate as well. But just, identifying, building it, getting the resources, having them available, kind of knowing how to piece things together to get the patient here, having them support and get into treatment. We get a lot of donations of gas cards. We get those. Those are great. But then also, you can partner with Uber and Lyft to get the patient, get for transportation. But just trying to randomly think of different things because there's constantly things that come up. I brought up the wheelchair ramp. You wouldn't even but that was a huge concern for the patient to get out of their house. Yeah. And so we found a local community that went out there and built it for the patient. It was awesome.
You'd be surprised at how many. So we have a coding. We don't use Z codes, but we have our own code. We've been doing this for 27 years. So we have our own system of codes that we've developed. We have 175 different problem codes and then about 170 something resolution codes. And there's often not a one-to-one correlation between the problem code and the resolution code. So you'd be surprised that there's usually something you can do. It may not solve the exact problem that the patient called with, but you may find something for them. But, there are just some, the safety nets are very, just like the healthcare system, the safety net environment is just as complicated and just as fragmented. So having experts that know how to navigate that world and know what types of eligibility criteria apply to what kind of resources. Unfortunately, there are certain types of patient archetypes, if you will, that don't qualify for much. If you're making 500 or 600% of FPL and you've got insurance, there's not a lot out there for you. But there are some patients for whom they have eligibility for a lot of different things, especially means tested patients. So there's a science to this, so you can start to deploy to make it more efficient and more effective, so that you're not spinning your wheels trying to find that. And we have a pretty good sense of the things that are really hard to find, like help with burial expenses is a good example of something that's really hard to find for patients.
What financial screening tool is used? My organization has patient financial advocates, but it's a small team, so it would be great to refer high-risk patients.
We actually have a couple tools in place. We have a tool that's it's kind of like a propensity to pay, but it gives us an insight before we talk with our patients of just where they are on the FPL chart. And it's based off their debt to income. But that's a tool that we use. We also, of course, like we talked about the distress screening tool, we have our new project in place for our food and nutrition, and then just start educating our financial counselors on what to look for, and what words, what things to ask and ways to ask different ways. And then for our out-of-pocket assistance, we have tools in place for that identify the assistance right away, whether not just out of pocket for treatment, but also other programs that are available that assist with transportation, and you can just actually enter in what you would like to see or what you're looking for. So I think a multiple of tools is important to have, and we continue to look. And I know, like a Nexus Health with Assist Point, that they have a really good tool in place, and you're able to just continue to build in different resources. So it makes your search a lot faster, or you're not spending a lot of time on Google. So those are some tools that we use.
So for us, we don't have a screening, like we don't actually have a distress tool or anything we use for patients. It literally starts with, why are you calling? Just like if you show up in the emergency room, why are you here today? And we take a body of information that's kind of the diagnostic set, if you will, about key information that we know can differentiate what you may or may not be eligible for, your insurance status, your income, et cetera. So there's that level. And what are the key sets of information we take from a patient? Because those are the things that become really relevant in trying to figure out what they may or may not be eligible for. I think the question, though, is more about, what type of is there a screening tool that you can use? Because I think we will have to start screening for these things. And while we don't use one, we've tested quite a few. And no offense to the people who have built really good distress screeners, they're not very specific or sensitive to financial distress. And even the ones that are specific to financial distress, unfortunately, are not very specific and sensitive to the very unique dimensions and ways that these things manifest themselves. So they don't capture things like utility shut off, or maybe not capture a transportation problem. So I think you've got to be really specific, as you're talking about with the story you told a little while ago about actually using a questionnaire specific to food. I think you've got to figure out are there a set of issues that you feel comfortable that you can really help address for a patient, if you're going to put a screening tool in place, and have tools that are really specific of addressing those needs. So a general distress or a general financial tool is probably not going to help very much in that kind of setting, because it's not specific or sensitive enough to the different types of problems that you got to unpack so many more things to actually get to what is the problem. So you're better off just saying, what's the problem, rather than playing 20 questions. Or if you're set up really well to be efficient with housing or food or transportation, just focus on those questions and don't ask sort of the big, and try to drill down to those, more granularly. Well,
Yeah.
does that sound weird when it came? Okay.
You mentioned some online financial calculator tools. Can you share where these can be found?
We actually use it through Nucleus, and it's called a protocol analyzer. And we're able to build in our fee schedules. We build in all of our regimens, and able to put in a patient's live out of pocket, what they have at that current time, and then also the ability to add in any foundation assistance we were able to secure or copay card assistance to really get as close as we can estimate for that patient, and be able to break it out, which has been very helpful for a patient, especially when you have that out-of-pocket assistance. It takes away that sticker shock of that large amount. But that's a tool that we use for estimates.
And we don't have that. What we built is, we call it our financial resource directory. And so as our case managers are looking for things, they put them in a database, and then we actually put that information into an accessible, searchable directory that our case managers use, and anybody can use it. So it's based on a few key questions that really help kind of surface what are 5 or 6 types of resources that may be available. It's a bit of a crude instrument, but it's a pretty good starting point to help sort of get down to 5 or 6 things that may be a good possibility for somebody who has breast cancer, lives in Florida, and has, commercial insurance, and is, under a certain amount of the FPL. So that, and other we're not the only one that has something like that. I don't mean to just promote our tool, but we have lists of all the tools that are out there that do that kind of thing. So you don't have to use ours, but there's some other good examples. I just put ours out there as one.
So much of what we've talked about is how do we scrape up emergency services for our patients when in need? And you're both experts. You've been in the field collectively a long time. In the ideal world, what are the solutions to solving these issues? What would be the top 3 that you think we should be working on as a nation to build an infrastructure that will support people?
It's a great question. My first thought is we talked about insurance optimization. I think that's huge. I think it kind of starts there, and then, identifying what those other impacts the patient's going to have and building up those resources. But, I think with the insurance, for me, in my mind, it starts there. I don't know about
I'd say you kind of need 3 pieces that are must-haves. You need community liaisons, as I already described, not doing the work of hiking and hunting and finding the resource, but actually creating the trust and reaching out into the community, understanding what's available. There's a lot available in a lot of communities that the health system just doesn't know about.
Right.
So that's part of bridging that gap between the health system and the community in ways that haven't been done before. And the second one is patient navigators, right? So somebody to actually do the work of finding things. And that, like I said, is something that it's nice to have within your 4 walls, but it's also something that can be scaled outside those 4 walls. And the third thing is the technology, right? You have to build, and I don't necessarily mean patient-facing technology, although you'd be surprised. There is definitely a digital divide in this country, but there's plenty of low socioeconomic and racially and ethnically diverse patients who have smartphones, who are happy responding to surveys on text, have access to the internet. So it's not, we shouldn't run away from it or be scared of it because there is a digital divide, but it's not as big a cause of disparity as you might think. So you have to have other modalities, but there is an opportunity. This is a place where technology can actually bring some efficiency of gathering and analyzing and cultivating that data in a way that makes it more actionable to the people that are actually trying to provide the help and provide the assistance. So I think without technology, and if you're not going to be able to scale this. Now, there are certain patients, right, that have to have a person, right? But if you think about levels of difficulty, right? Some patients have really hard problems that really need a person to help get them through it and figure it out because it's so unique. But we also know some of these problems are they lend themselves to more efficiency and higher volume. So you can actually differentiate, problem sets and solution sets and patient types, and actually, start to think about these patients. They're going to need somebody to literally spend time with them, hold their hand, and get them through this. Others can be addressed and have their problem solved through lower touch, higher volume, sort of more efficient means. And I think we have to apply that kind of systems engineering to this, or it won't work. And again, this sounds like a nicety, but we're running towards this idea of ignoring social risk and social needs and social determinants in the context of healthcare is gone. And the technology around screening and diagnosis is coming. And what we really need to think about, because what do patients want more than anything? Yeah, they want to know they have the problem, but they want to know, what are you going to do to help? So if we build this infrastructure around screening and diagnosing people with social needs and financial needs and don't build the intervention, we might end up actually creating, to your point about trust, like we might actually create a system that builds more distrust and actually create, ironically, a system that's designed to address and really pull these things through could actually create some disparities and inequities just because of the system doesn't work for everybody. And you have to be sensitive. And that's another thing we're testing is people have to be able to respond and react to these things in a way that's meaningful to them. We have to, that's sort of coming back to where we started, why afraid of terms like financial toxicity, because they tend to be clinical and they make it sound like something that's scary. So I think we don't have the terminology yet, but we're working in sort of consumer testing, if you will. What are the right words and phrases? As you said, you have to be really careful with how you talk to patients about these things, because you can end up really creating shame and stigma with patients as you're trying to do the right thing for them. And of course, the first rule is do no harm. So that level, how you communicate and how you address and bring these things up for patients is really important. And you can't just wait. That's the problem, is because we know when you wait for people to come to you, the people who are more likely to ask either have a really big problem or they tend to be white, higher educated, higher income. That's just the truth.
Yeah, which points back to that bear poking question, right?
There's so much out there in the community that people are just not aware of. And so figuring out what you need and then figuring out how to ask for it. And then for our practices or our navigators or counselors, advocates, is to take the time to build those resources, to find them, to identify them, to put your stuff, put your resources together and have them on hand, have them ready, and continue to make those relationships out in your community to have the resources. And I think you made it, your last statement was great, is that the technology that, we're there, we're moving there. It's just going to continue, and everybody has a cell phone. And what a great way to communicate. You get a reminder for your appointment or a reminder for your bill. Why not I text like, are you okay? Like, do you need food? Do you need a ride? Those type of things.
I would just say, maybe ending on a positive note, remember that the essence of a good healthcare experience for patients really comes down to whether they felt respected, listened to, and that their care was personalized to them. And we get caught up in for good reason, around precision medicine and precision diagnostics and that aspect of the personalization of care. This is a way to personalize care in a way that's really meaningful and personal to patients. And it's not clinical, it doesn't require science, and it really speaks to things that they're experts in their own life. So this is an opportunity to connect with patients in a really meaningful and powerful way if it's done right. And that's a good thing. And what we know from patients, if those three things are there, respect, listening, and personalized care, even in the presence of poor outcomes, patients still feel like they had a good experience. So at the very least, if you build a good system of really, that's why I started with this idea. If we think about this as a way to sort of wrap your arms around patients in a holistic whole care way, even if you can't do something for that patient, because we aren't able to do something, but those patients are still appreciative that someone cared enough to ask and tried. And so there's a lot of trust and goodwill that you can build with patients in your community just by caring enough to wrap your system around these issues. So you're not just thinking about the clinical dimensions of care, but you're thinking about, and this is what every clinician wants. You want to think about your patient as a human being, as a person. So why not create those opportunities to make those connections in ways that are actually meaningful and relevant to their care and the outcomes of their care?
Thank you both so much, April, Alan, for coming out and talking with everyone today about such an important topic, for starting to talk about such an important topic, because I think there's a lot more to come. The hour always goes by really
we're cutting into reception. We could do this all night, but there's, I think, alcohol out there. So
yes, there is.
On Halloween. So.
There is. I want to say thank you to everybody in the room for everything you do each and every day for those at risk and diagnosed with lung cancer. We truly need way more of you out there doing all the good work that you're doing. So thank you so much. For Penn Media back in California, who's running the live stream, thank you all so much for what you do for this programming, and for all of my go-to colleagues who were able to be here today. I just love working with you all and love what we do. So thank you for all your support as well. And that's it. Let's go have a glass of wine.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.